and he's written a lot about hair. He's publishing a lot, and he's going to talk to us about alopecia areata.
Thank you very much, Professor Shapiro. I am very happy to be here today to talk about alopecia areata. You know, this is a very common and classical condition in dermatology, but there are some news that we must know to treat better our patients. And I'm going to review that along my talk. These are my conflicts of interest. Just a few words about my practice. I am working in the public setting at Ramón y Cajal Hospital, University Hospital in Madrid, and also in the private clinic Grupo Pedro Jaén with a lot of friends and colleagues that you can see in the picture. I am very happy to work with them because we are really a team, a working team. Well, you know alopecia areata. It is an autoimmune disease by which the immune system attacks hair follicles, and it is an non-scarring hair loss, so the hair can come back. The disease affects more or less 2% of population at least once in their lives, so it is pretty common. Of course, the severity is different between patients. We're going to see that. And it can have a devastating effect in patients that suffer from it. 70% of patients can suffer depression, 65% of patients anxiety associated to the disorder. And as I was telling you, the phases of alopecia areata are very different. It is not the same having a very mild case of alopecia areata, a patchy alopecia areata that can be managed with some intralesional injections that are easy to perform, and you must know them as dermatologists in order to do it properly and avoid atrophy and any other side effects. But when things are more difficult is when patients have these severe cases of alopecia areata. It can be patchy, it can be moderate, but it can be also total or universal alopecia areata. That's where systemic treatments are taking place, and oral JAK inhibitors are the most important therapy nowadays. How can we assess severity in alopecia areata? Well, we have this SALT score that is very easy. It gives us a number, and that number is the percentage of hair loss that has been lost. So SALT 50 means that 50% of your scalp has been, of your hair has shed, and SALT 100 means that you don't have any hair at all. The European consensus divides this SALT score into 3 categories. Mild alopecia areata, that is for patients with 20% or less of their hair scalp loss. A moderate alopecia areata, between 20 and 50 scalp hair loss. And severe alopecia areata, when patients have a scalp hair loss of more than 50%. And this is very useful to classify our patients, but it is not enough, because you know that it is not just hair. The thing is that there are other clinical characteristics that may play a significant role in assessing the severity of the patients. The first of all is the psycho-emotional impacts, negative impacts of alopecia areata. So if a patient has a mild grade of alopecia areata, if they have a huge psychosocial functioning impact, then they have to move to moderate, or if they have moderate, to severe. It happens the same if they have any involvement of eyebrows or eyelashes, and also if they don't have a correct response to treatment after 6 months of treating it. There is another clinical situation that you must know, that is diffuse positive hair pulse test consistent with rapidly progressive alopecia areata. This is acute alopecia areata, and it is pretty different from other situations. In fact, this European consensus divides alopecia areata into 2 categories, or 2 clinical presentations. Acute alopecia areata, this is not the most frequent one. It is so rare to see it, but you can see it sometimes. It is our alopecia areata that started in the last 6 months, and it has a rapid course of the hair loss. Then you have to take actions rapidly, and you have to start oral or systemic corticosteroids. This is very important because sometimes just sometimes, those patients will be fine after a course of systemic corticosteroids. So that is really useful for them, and they can be an isolated flare-up of alopecia areata in their lives. But the most common situation that we all face every day in our consultation is chronic alopecia areata. This chronic alopecia areata need to be treated with JAK inhibitors. And these are the JAK inhibitors that now are currently approved or are going to be approved very soon for alopecia areata: baricitinib, ritlecitinib, ruxolitinib, and upadacitinib. You probably know what is the best for alopecia areata. And I can't tell you, nobody can, because there are not face-to-face clinical trials to assess what is the best option. All of them are very good news to treat alopecia areata. 3 years ago, 4 years ago, we didn't have those options to treat our patients. So this has changed the way we treat our patients, and it is really a very hopeful scenario. The most important you must know is how they work. I mean, clinically. You must to maintain the therapy at least 9 up to 1 year to see that if it is a good treatment for your patients, or you need to change the therapy, because they work slow, and they work slower in the most severe cases. I really like this article, this study that showed us how there are clinical response patterns in alopecia areata patients. In this case, is under ritlecitinib. We can observe on your left early responders that are patients that will be fine after 6 months of therapy. Also, middle responders, they have to wait up to 1 year to get any response, and late responders that they will need even 2 years to get the best response. And as you can see below, as the more severe is your case of alopecia areata, the more time is needed to get this positive response. So you have to be aware of that, and patients need to know it also. There is another category that are non-responders. Among them, we have partial responders. That means that they are going good, but then they don't get that endpoint of SALT below 20. They are above that, but below 30. Relapsers, these are the most difficult situations. Patients that are going really good, but then they have a relapse. Then they have a positive response, but then another relapse. This is so difficult to treat, and we have to change and combine therapies every time. And non-responders at all. In some clinical trials, that number it's up to 30%, so 1/3 of patients. But this is under clinical trial. It is not real clinical practice, but it's good to know because we're getting more and more data for clinical trials. And you see this case, for instance, these are middle responders. He was very worried. Their parents were really worried about how he was after 8 months of therapy. We didn't do anything at all, and after 1 year, we started to see positive results. And in this case, after 1 year of therapy, he had some improvement, but almost nothing. But we used trichoscopy, and we observed this short-growing hair, so we were hopeful, and we started to combine baricitinib with dexamethasone, and then he started to have his hair back. And we had the opportunity to publish this, the combination of baricitinib with corticosteroid that can be really useful. This is a total of 25 patients who received baricitinib 4 mg daily for 5 months. After that, we observed a positive result in 12% of our patients. It's true that 88% of them, of the rest of patients, we had some partial response. But we were sometimes, to get this treatment reimbursed, we have to be a little bit hurry in Spain, so we started to combine baricitinib with corticosteroids, with intramuscular corticosteroids or oral dexamethasone. And then, after 3 more months, we observed a positive results in 60% of our patients. So that will be very useful to treat patients to get better and quicker results in some cases. And there were not significant side effects in our cohort. And another question is, how can we predict if our patients will have a good response to JAK inhibitor therapy? Well, we have some data from clinical trials, but I want to share with you some data from real clinical practice, because we are getting more and more data in real clinical practice. Among this cohort of patients, 70 patients treated with baricitinib 2 to 4 milligrams daily after 9 months, they got positive result in 41% of them. And the positive factors related with this positive response were shorter disease duration, the episode of alopecia areata, I mean, also the combination with corticosteroids that was offered to some of them, and female gender. So women will be much better with treatment than men. And negative factors are very severe cases of alopecia areata and the ophiacis alopecia pattern. That is a very classical pattern that is independent of the SALT score. So duration of the disease makes a difference a lot. We saw it in the very first results from the first clinical trial on alopecia areata, and we observed how having an episode of alopecia areata of less than 4 years was much better than having that condition for more than 4 years. So time is here. As dermatologists, we must know that as the sooner you treat your patients, the better outcomes you will have. This is very important. And then we have treated our patients with baricitinib, with any other JAK inhibitor. When can we discontinue the treatment? Can we stop the treatment directly? Well, we know that it is not a good option. It is not a good idea, because after 14 days, the relapses are really common. And even in clinical trials, we observe that. So, but we have to know also that spontaneous relapses are also an option. That patient was under ritlecitinib, and he had these tiny patches. He didn't notice them, and it is normal. I have seen this with baricitinib, even with the ruxolitinib during clinical trials. So it may happen, tiny relapses. And if the relapses are with a SALT of 20 or less, without visible cosmetic concern, well, there is one very first option, doing nothing, just wait, because it will be fine. But if you want to treat it, you may consider intralesional triamcinolone injections, and you may consider also add oral minoxidil to these patients. There is not hard data talking about the effectiveness of oral minoxidil in alopecia areata, but there are some good studies telling us that the combination of oral minoxidil with JAK inhibitors may help our patients to maintain the hair regrowth for long periods of time. So I encourage you to use it, as it has a very safety profile, as Dr. Luis Dueñas explained previously. And what about if they have a SALT score of more than 20? I mean, this can be cosmetically concerning to our patients. Then think, first of all, to increase the oral JAK inhibitor dose. Maybe it is just enough, but if you have decreased it previously, it is a good idea to retake a higher dose, probably. Then consider corticosteroids, intramuscular oral corticosteroids. So yeah, I am talking about the systemic corticosteroids, because of course you can inject patches of alopecia areata, but if the extent of alopecia is too large, I recommend not to inject the whole head. And then, again, think about oral minoxidil if they are not taking it. And what about switching to another JAK? Well, that's a new frontier. We don't have data on that. We don't really know when to change a JAK inhibitor. There is not a rule. You can think about efficacy, about time. This is my personal recommendation, but I can change it in a year, because new data will come soon. I'm pretty sure of that. Maybe if they have a SALT above 30, I mean too large. Also, if they have multiple relapses in the past 6 months, because if they have it, maybe they are not stable, especially if they are under JAK inhibitor and corticosteroids. And finally, if they don't have satisfactory hair regrowth in the end, because sometimes they have a good SALT score, but the hair regrowth is very diffuse, very weak. So maybe if the patients are not happy, you can talk to them to change the therapy. So this is the situation, but this is not on books, this is not publicated, it is just a personal recommendation. Okay, so to summarize, alopecia areata has many phases. Treatment must be individualized to each clinical presentation. We must assess severity, and we have to know how to classify our patients in mild, moderate, and severe cases, and also to distinguish between acute alopecia areata and chronic alopecia areata. Therapy in alopecia areata takes time. That is the most important. I know that you have experience with alopecia areata, but some of you may not have so much experience with alopecia areata. Then be patient, because you have to be even more patient than your patients. And then red flags in alopecia areata today are SALT score above 95, that is mean alopecia areata total, episode of more than 4 years of duration, male gender, and the sustained efficacy of JAK inhibitors has been proven. So don't stop the treatment unless there is any other medical or your patients wish to do it. Thank you very much for listening to me, and enjoy the Congress.
Thank you so much. Thank you so much. And it's my great pleasure to introduce